Hello, I'm Dr. Trites, and this is part one of a five-part series, and this one's entitled Your Exam and Laboratory Basics. Everybody should be having an annual physical, and what is performed there? Do you get your blood pressure? And when you do get your blood pressure, was it performed properly? We're told throughout school that you're supposed to do it on both sides in order to get a balance, and that balance should be within 10 points. Is a physical thorough? Do you have vibration? Can you feel the vibration in your fingers and toes? Can you hear it in your head? Is there a difference between the left and the right side? This DTR stands for deep tendon reflex. You've had somebody take a reflex hammer and tap you on the knee. Has it been both knees? Has it been both ankles? Has it been both wrists? Has it been both elbows? All those are reflexes called deep tendon reflexes, which really tell you about the nervous system. But one spot only tells you about one spot. So there are six different deep tendon reflexes. Also pulses. Have you had your pulses checked? Is it just the pulse that's on your wrist? Is it the pulse also on your elbow, on your groin, behind your knee, top of your foot? Those all tell a story. So just texting one of them, taking a look at one piece of it doesn't get the job done. Have you had any new conditions when you've come in to see your doctor for this one-year exam? Example, you might have had a loss of smell, a difference in taste, a change in memory. I don't remember them the way I used to. That is actually a problem. Do they do a urinalysis? Do they do any blood tests? And I put in here report versus call. A lot of my patients get a phone call that says, hey, everything's fine. What does that mean? Have you looked at it in a certain way? And I'm going to get to that in a minute. And then something I'll talk about TSH versus thyroid. A lot of people say, well, my thyroid's been checked. But in reality, the only test that's been run is the TSH, which is a thyroid stimulating hormone, which comes from the pituitary. It's really not even a thyroid test at all. It's a pituitary test that is supposed to tell the thyroid how to work. So when they said they have their thyroid tested, and that is all that's been tested, that's not necessarily true. There are 8 other tests that we can look at to evaluate if the thyroid's working properly, been stimulated properly, getting the information, assimilating, making the thyroid hormone, and is that getting processed in the liver and in the gut, and then brought back to the hypothalamus to tell the pituitary to make the right amount of TSH. That is a thyroid test. Other necessary tests is your temperature run? Do you have functional neurology? And I'll get to that later, I think, in uh, this session. And then oxygen saturation. What is? Are you putting enough oxygen out when you breathe? Are you getting it in? Do you have any balance? Can you stand on one foot? Can you stand on a foot with your eyes closed? Can you walk back and forth talking? Can you remember a couple words that we've said maybe 15 minutes later? And then, of course, functional movement. So this is part one of laboratory testing. When we have to create a reference range in the lab, we look at this particular thing called standard deviations. If you're in the first standard deviation, that is considered completely normal. There's a little bit of variance between, let's say, 1,000 individuals. When you get to the second standard deviation, you're not in that probability. You can see that 14% of individuals are outside of that probability. This is where we lie in the world of functional medicine. You're not necessarily sick, but you're not necessarily healthy. You're not within that 68% of the rest of the population. And then there is that 2% that gets out. This is what we call lab levels. If you're 2% on one side over here, you are definitely higher than others, and 2% on the other side, you're definitely lower than others. But the reality is, if you get in that second or the first standard deviation, there is something going on that needs to be addressed, and that's what we take a look at. So when it comes to laboratory testing, most doctors do not understand this. Specificity versus sensitivity. And specificity means, can we find what we're measuring? Sensitivity is, if it's there, can we measure it? And accuracy is specificity plus sensitivity. Blood shots in reality are really a snapshot in time. Now they can give us a story, they can tell us what's going on, and sometimes we have to have multiple snapshots to get a better story. And that's why we like to have you bring in your old labs just to get an idea. Because sometimes that accuracy is not good enough, or that snapshot is actually good for 3 to 6 months versus another snapshot, let's say glucose or blood sugar, is only that very moment in time. Because you can go and eat something or you can go do something and that blood sugar can change immediately. But an allergy to a particular product, let's say gluten, doesn't change in 5 days or 10 days or even a month. So advanced laboratory, I have to talk about cholesterol. The basis of cholesterol was called this Framingham study, and they injected animal fat into rabbits. And of course, the rabbits started to have what's called tunica media thickening within their arteries, and that was when cholesterol got its bad thing. There are some good things that have come from the Framingham study. I'm just trying to get you an idea that some of the research that's out there wasn't exactly, in my opinion, very scientific. It was using the wrong model to get a particular result. So what is a good cholesterol number? Just letting you think about it. Most of you have been told that 200 is good. Probably in 1990 it was 220, and pretty soon it'll probably be 190, 180. What is the average cholesterol for most heart attacks? And most people would think probably over 200. Well, it's actually like 173, which is considered okay. So there's a particular set of cholesterol tests we do called the Berkeley Heart Test, which I'm going to show you in like the next slide. And then there are genetic tests that we can do specific for disease or disease prevention. We're looking to see if you have the potential for setup for Alzheimer's or Parkinson's or macular degeneration or an autoimmune case that we can get very specific to. I'll take a moment to talk about what's called the Eisenhower Paradox, and this came from a book called Good Calories, Bad Calories by Gary Taubes. So President Eisenhower was the most chronicled heart attack survival in history. They drew his blood all the time to take a look at his cholesterol. When he had his first one in 1955, his cholesterol was 165, a level that's considered safe today. After his heart attack, he did everything he could to eat what they considered a high cholesterol diet, and his last day in office, it was 259. It had gone up. So it's not exactly all about cholesterol, it's about the size of the cholesterol. So while this is a terrible slide, hopefully you can see everything that we have on here. On the top left, it just says lipid panel and cardiovascular risk. And this got the old things that we've always seen before: cholesterol total and HDL, which is considered good, triglycerides, which is how your fat goes through your body. It can be converted to fat, or it can be used again and converted into sugar. So if you eat too much sugar, your body will create triglycerides and turn it into fat. LDL, cholesterol, which is considered bad, and then a score, like a ratio. What is the ratio between the two of them? And then there's other things, chylomicrons and other sizes that are considered non-HDL cholesterol that we also take a look at. Now, the next one down says lipoprotein subfractionization. This is probably the most important part of this, is because you look at things that are small and things that are big. In all reality, if you have a lot of small particles, doesn't matter if it's HDL or LDL, those small particles have ability to go inside of the muscle, which is the artery, cause inflammation, and eventually what's called foam cells. They'll push out, and that's what your plaquing comes from. And risk factors for that, so these two things below it called apolipoprotein A and B, and then also inflammation factors such as C-reactive protein, fibrinogen, and LPPLA2, which is you're actually looking for how much plaquing do you have in there, the ability to it. And then is there any type of heart failure markers? Are there any metabolic markers? This is the big one we look at most in most of our patients, called homocysteine. It's not just for cardiovascular, it's for other things, but it's big onto that. We know that if your homocysteine is above 10, you have the ability to slow down blood supply to the brain, which is neurodegenerative, meaning everything slows down. So in this particular case, this test subject has a high homocysteine. Also, we look at vitamin D, as it has a response. Vitamin D technically isn't a vitamin, it's actually a hormone. And then insulin, as blood sugar has so much to do with cardiovascular health. And the last thing down here, I just ran one genetic cardiovascular marker, which is to aspirin. This tells you if you have, if you will respond to aspirin or not, based on your genetics. I'm going to stop there today. Thank you for your attention. If you'd like some more information, please call our office or contact us at doctorsoptimum.com.